Hi. Okay, we're just gonna keep the space open and see who shows up, and then we'll get started. Um, and let's see how it evolves. I see we have three people so far, which is awesome. Rocky, do you want to see if your audio works, just so we make
Oh, yeah,
sure?
sure. Can you hear me?
I can hear you perfectly.
Awesome.
Perfectly. Yay.
Yay.
Good. People are coming in. We'll give it a few minutes and see if we can get a cohort going and then start our talk for the night. For everyone who's coming in, thank you for being here. And I know we chose kind of an odd time where a lot of people are doing bedtime and a lot of people are doing, you know, post-work activities. So I heard from a lot of people that they couldn't make it tonight because they had to chart, or they couldn't make it tonight because they were still at work. And so, I think it's a good segue there. But let's give it maybe 1 or 2 more minutes. We do have the recording button working, so this is something that we can replay for everyone. But I'm optimistic that we'll get some people joining us so that we can so that we can have a really nice, involved discussion. And if not, we'll have a nice, short and sweet discussion, and maybe, come back to the topic over time. Part of this is a natural evolution from our last one. Um, so I think it'll be a good talk. Let's see. How nice is it to not be on video, by the way? I love this. I love spaces because, you can just have your hair in a side ponytail and nobody knows. And I love it. Um, good. Oh, good. We're getting some more people here, some familiar faces. Nice to see everybody. We are
Yeah,
just getting set up and giving some people the chance to come in, and then we're going to get started.
going back to your your comment about not being on video. Before we got on, I was like, wait, am I gonna be am I gonna be seen? I was like, oh yeah,
I
that's right.
love it.
It's spaces.
Although it's, to be fair, I did FaceTime you right before we started, so
You did, but that was
I
okay.
kind of ruined it. We
No,
know each
no,
other.
we're friends. It's all good. It's all good.
Good. Okay. So, welcome. I think we'll have people trickling in. We do have the recording feature on so that we can make sure that people who couldn't make it tonight for whatever reason, life gets in the way, they're able to listen to our talk. But I wanted to just introduce myself. I am Eve Bloomgarden, and I am one of the leaders of the Women in Medicine nonprofit organization and the chief development officer, and I've been running the Twitter Spaces. This is our third one, so very excited about that. And I just wanted to welcome everyone here. I'm an endocrinologist by day and sometimes by night. I'm someone who, has very much gone through burnout at different times in my career, including, these last 2 years. It's always a struggle, I think, for so many of us. And I'm really eager to see what stories come out, and if anyone has anything to share, any solutions. It's been a topic that really keeps coming up, and the pace with which it's coming up, I feel like, is accelerating a bit. And we're all, I think, feeling the pinch of that. So that's kind of the background of the space. My co-host is here, Dr. Bayani, and I'm going to have her introduce herself and give a little bit more of the intro and kind of transition from our last space, and then we will let the conversation evolve from there.
Yeah, hi everyone. My name is Rocky Bayani, and I'm an internal medicine physician at in St. Louis, Missouri. I work mostly with residents that are training to become physicians, and I also run a professional development initiative for our women trainees in the Department of Medicine. And I'm also actively involved in the Women in Medicine Summit with the programming committee for planning our next summit, which will be in September. And this is my second ever Twitter space, so I'm super excited to be here. And then just in terms of our topic for tonight, we had our last Twitter space, I think it was last month, and it was really on sort of the Great Resignation and people leaving, and people sharing sort of their experiences and their stories. And one of the topics that sort of is probably on a lot of people's minds are just sort of this burnout and what's happening in healthcare professions, and as even mentioned earlier that a few people had told her that they couldn't attend tonight because they were going to be home charting or doing other things. And so I think that sort of speaks to why this is an important topic. And what we really wanted to do is just sort of talk a little bit about sort of, hear from other people in terms of their experiences. What strategies work for you. What are some of the things that you're doing either as individuals or within your organizations to sort of help navigate some of the stresses and challenges that we all sort of experience in the workplace.
And we would love this to be interactive. So if anybody wants to speak, just let me know. This is my first time moderating a spaces, so bear with me. And if I don't know who you are, or if your account is locked, send me a message so that I know that you're real. We're going to keep this space civil and kind. It's National Doctors Day. We're going to try and keep this space not necessarily, it doesn't have to be positive, but it needs to be appropriate and polite and kind. And we're gonna maintain that. So I'll cut you off if you're not being kind. I think part of what's going on, I think, has really hit home for me in the last few weeks as I started a new job, and what I've noticed that is different than when I was off for maybe 2 months, and patients are noticing that their doctors are much more burnt out than usual. It's coming up in almost every patient interaction. By that, I mean either patients telling me that their primary doctor has resigned or is planning to resign or looked really tired at their last visit, or that they can't get in to see a specialist, or nobody calls them back from multiple offices. And all of these things, I think, are really symptoms of this, what's happening in healthcare. And we're seeing it in nurses, we're seeing it in doctors, we're seeing it in pharmacists, we're seeing it basically in anybody who works within the healthcare system. And it's not a new problem, meaning obviously burnout, or not obviously, but factually, burnout was a big issue in healthcare and in medicine prior to COVID, but COVID really laid bare all of our weak points. So, it put extra stress where we were already kind of just hanging on. And then in addition, it's 2 years of, chronic stress and loss and grief, and a lot with the pandemic. There are a tsunami of patients who need to be seen, who are a little bit sicker than they were 2 years ago, because they missed appointments. We have high turnover in the staff. And so, everybody's a little bit new, and it's very hard to train staff quickly in this kind of environment. And it's basically just kind of a ripple effect. And so I can't get through a patient interaction without really addressing it front on. And that to me was a startling change from a couple of months ago. One of the other things that has really struck out to me over the last few weeks is really the absence of solutions that are that seem to be coming through. And by that, not just one health system, but in general, as I talk to people around the country, people are really struggling with burnout, and a lot of people have one foot out the door already. There was a paper today, which I can share in the space, that 1 in 5 physicians plans to leave medicine in the next 5 years. I think was that. I'll double check that reference, but I'm not surprised at all to hear that. And I think it's going to be something little that causes everyone to kind of leave, and there are some simple solutions that could be implemented that haven't been. And so, that's kind of where I'm coming from, which is, if we can fix something before it gets worse, why are we waiting on it? And I feel like we had this opportunity to take advantage of the disruption that's happening, and the fact that for so long we wanted change, and now we're at a point where it has to change. So let's kind of move together to make that happen. So that's kind of where I'm coming from. I would be interested to hear, if this is an experience shared among other people in this space, or is it unique to what I do, or where I live, or my field, which is endocrinology. Is it outpatient versus inpatient? What kind of stressors are unique to each specialty, and also what kind of solutions may be unique to those specialties as well. So again, I'm not really sure. Let me make sure that nobody is trying to speak. So I'm going to turn my mic off for a second, but then we can continue. This.
Yes, if anyone wants to join, come up to the stage and sort of share some of their experiences, or we want this to really be a space of like just kind of peer support. So it's a place where we can sort of have an open dialogue. and, share sort of what's going on, on your mind, and, what's happening sort of in your area, or maybe things that you think have worked for you. I know for me personally, there's been this sort of uh, push for trying to really help myself in some ways recognize, um, you know, creating boundaries. So when do I say yes? When do I say no to sort of opportunities that come up? And that's one small thing that sort of that I've tried to be better about. So, that's just sort of one strategy that I've started employing, as I've gotten farther along in my career. So, um, love to hear from the other people that are up here on the stage now, ready to speak.
Perfect. So I know I see Suba's here and Dr. Natalia's here. So let's hear from Suba, and then we'll keep moving through. And thank you guys for making it easy for me to bring you to the stage.
Yeah, my pleasure. So really happy to be here and thank you for talking about this. I feel like everywhere I turn, we're talking about this. And, as I talk to colleagues, we keep thinking, well, burnout has been there for a long time. Obviously, it's gotten worse over the last couple of years, or at least I hear about it more. And I keep coming back to a lack of choice as being a big um, reason for why so many people are burnt out. Like a colleague told me today that two of his very close family friends passed away and he couldn't go to their funerals because he was on service and he couldn't get coverage for it. And when he brought it up to the group, there wasn't this overwhelming, like, sure, of course, you should go, we'll cover you. It was, oh, well, I don't know if that's an appropriate use of jeopardy. And then, we're seeing these criminal cases happening between obviously the nurse here at Vanderbilt, but then also I don't know if you all saw the case in England, but it's just, I don't know, it feels like it's reaching a breaking point. I don't know if people felt like that 20 years ago. I can't imagine that this is all new, but the lack of choice of being able to control the things that affect our jobs is really challenging. And sorry, I didn't introduce myself, but I'm Suba. I'm a hospitalist at Penn. I am now founder of a company, and now being an entrepreneur and being in a career which is, I spent 95% of my time outside of clinical medicine, I am completely struck by how people are treated as employees when they're not healthcare workers. And in fact, it makes almost being an employer really challenging because my sense of what's okay and what's not okay and what compensation should look like is completely warped. And I'm learning that as I'm going. But it's just, I had a friend in the business world tell me that he didn't ever realize that clinicians are basically like factory workers or treated like factory workers. So I feel like I'm being all doom and gloom. I guess what I'll say is what provides wellness to me is really talking to people like you who are so passionate and really put a lot of time into exploring ways that they can help others. Ways that I find that in my own day to day is literally everything I do from morning to night is aimed towards making it easier for clinicians to do their work. And it doesn't go as fast as I'd like, largely because, again, clinicians don't get to choose what they want to do or the tools that they want to use, particularly technology. But at least once a week, I have someone tell me that, something that they've used in my company has changed their workflow or changed their day or just made things so much better. And every one of those keeps me going. So finding that passion and working towards it has really been key.
Oh, Suba, I love what you said there. And this is to come clean. Suba and I actually just did a podcast or a video. I don't know what the right word is on this topic too. And I love your emphasis on the lack of choice, because I think ultimately it's really hard to look back and say over the last 2 years that we have given everything we've had to get strangers and friends and family and ourselves through really unprecedented amount of stress and illness. And then but we don't have the ability to say, I'm not coming in at 8, I'm coming in at 8:30, because somebody else is making these what seem like absurd rules for how our lives go and how we practice medicine. And I think it's the cognitive dissonance between what we think of as our value and the value that we're clearly showing. and the ability to make silly choices like, no, I really want to see, take 30 minutes for a patient and not 15, or I'm really sorry, but it's important to me to go home at a certain hour and to see my children, and like to not have any autonomy to do that is really, I think, is the crux of the issue. And then on top of that, what you mentioned is we've spent a lot of time dabbling in, or some of us dabbling, some of us creating companies in things outside of just clinical medicine. And what we're learning is really like how we're treated is not really normal, and it is not the standard across other types of professional work and or any type of work. And so, I think opening our eyes to the possibility that we could be in an office where, we have food or water or like potty breaks, right? Or
sick days that you don't feel guilty about.
Like,
Right.
oh my God, where you literally don't have to see, there are places where you don't have a meeting scheduled every 20 minutes, and then you don't have to spend 4 hours documenting everything that you've ever done that day into a chart. I mean, and so that, I think the whole piece of it is like, it's all contributing, but I think the key here is choice and exposure to the outside world have made things really pretty clear for a lot of us. And so people are taking other opportunities that they may not have considered 2 years ago. And every time somebody leaves the workforce, that kind of worsens the burnout for whoever's left behind. And then the next person goes. And we're seeing, in my opinion, we're seeing the dominoes start to collapse. So, wah wah. I was going to try not to do that. And let's hopefully not stay down this like Debbie Downer path. But I think it's really important to bring up like what's going on, and really like, name what reality is versus kind of our realities, so that we can know what we're demanding when we ask for better. Natalia,
Yeah,
I'll have you go. I'll have you speak next. Well, first we'll go to Rocky and then have Dr. Natalia go. Yeah.
I was just going to say, when you mentioned the lack of autonomy, I think that's really, really important because, when you don't have the choice, you just feel almost like you are sort of bound and sort of in a corner, right? So I feel like that's really important, whether you're a trainee, which you have even less autonomy. Being faculty, obviously, there's so many constraints as well. So the lack of redundancy in systems makes it really difficult then, like for your colleague that, or your friend that wasn't able to sort of leave at a time of, great distress and probably really felt terrible that they couldn't leave in that time. And so sort of creating that system where you have that redundancy, so it doesn't put an extra burden on people that are already sort of burnt out, is really important. And I think that's where a lot of this like work flexibility can come in as well. I mean, obviously with depending on what you do and what specialty you're in, there may not be flexibility, but what for me personally has come into play, especially with the pandemic, I work part-time, but a lot of times my meetings end up happening on my days off just because I'm clinical the other times. At least now with with everybody doing things remotely, I don't actually have to go into the workplace to have these meetings. I can at least do them from home, which is kind of nice. And having that flexibility can be really important. So I think that's another sort of strategy, I feel like, just to sort of being able to have some of that flex time, so that maybe you do want to be able to work from home and on your admin day, and maybe be able to pick up your kid or do something like that, but then you work, you just have some flexibility in the hours that you have.
Absolutely. Natalia, Dr. Natalia, let's invite you, or you're already on the stage. Let's have you speak. Nice to hear you.
Hi, guys. As Eve, I'm an intensivist, and I just wanted to share a few thoughts that came to my mind recently. So, literally, over the last weekend, I spoke with a friend of mine who is an ER physician in Texas. And we actually were talking about burnout there. And he shared something. Their program had really struggled a lot in their hospital, also with burnout. They have cases of suicide and homicide amongst physicians, and also had a lot of physicians having like anger bursts in the middle of something, and then they been basically kicked out of the hospitals for those moments. And what he said, something that we keep calling it a burnout, but basically this is a depression. We are just not calling it a depression, so we don't admit that our healthcare workers, particularly physicians, are depressed. Maybe different degree of depression, but we have so many suicides among physicians, which we know that usually people who are depressed end up committing suicide. So we come up with some kind of masking terms that don't bring any strategy. But for if we were to say that this is a depression, then we know the main thing is, first of all, I mean, you have to do a cognitive behavioral therapy, and I'm not a psychiatrist, so I wouldn't go into, but at least there is a help to it. When we said burnout, I remember I was in fellowship. When we said that fellows were burned out, they did 1 day in a year of some kind of retreat where we listened to singing bowls, we meditated, and that was what program offered to us as fellows, burned out ICU fellows. And so that was one thought that came to my mind, that maybe if we really address it as, not just a burned out, but it's really maybe we need to do a screening for depression among physicians, and recognize the physicians are depressed, then maybe our strategies will be different. Second point I wanted to say is I reconnected with my friends who are hospitalists. Between residency and fellowship, I did a couple of years of hospitalist medicine. And basically, everybody who I've started with, they're all gone from clinical medicine. They either do utilization review, they do anything they possibly can do, just not to do clinical medicine. That's a second point, that physicians are leaving at extremely high rates. And some physicians, if they have any other talents, if they are able to do anything else, they would do it, even for a lesser money. You know how always physicians have been blamed for being greedy or not giving up their salaries. Physicians are leaving higher salaries, but for better lifestyle, for lower salaries. And another thing that I wanted to say that struck me yesterday, there was an article, I would say, on modern healthcare, where it said that I think physicians are reporting a higher percentage of medical errors due to staff shortages and staff being not high quality as it should be, which I can definitely um, say that this is happening, because if we had ICU nurses who were trained by years and years and years, now we have ICU nurses right out of nursing school, and they have really poor, not poor necessarily, but they're just not there yet. And of course, errors do happen. And I think this becomes really scary right now because of the latest cases of criminal charges for being done for medical error. Like, I personally, it bothered me since yesterday. I'm still digesting this whole idea that amount of medical errors is going up, but the only person who is liable now, not only civil lawsuits, civil liability as malpractice, but also criminal charges, will be a physician. And
Yeah.
it's definitely.
I just want to echo that. I'm gonna cut you off just to keep the discussion going,
Okay,
but
okay,
because
sure.
and I'm so grateful that you mentioned those things. Those were three things that we had, said we really wanted to cover in this discussion. And I'll invite everyone who's speakers to stay on the stage, and if anyone else wants to join the conversation, it's my I'm moderating my first spaces, so please send me a request if you want to speak. But I think what has just been, what we're all kind of saying is, is it us? Are we all, is it like are we all depressed? Is that what this is? Is this moral injury? Is there something wrong with the system? Maybe the system is depressed. I really think that's really more of the problem. But what we're saying is we have been really conditioned over, all of our training to find workarounds and to stretch to our limits to make something that didn't really ever work well work. And we were doing it okay with what we could when we had extra, when we had extra hands on deck, and then when we had some redundancy in the system. But now we don't have any redundancy left in the system, and we have turnover. We don't have the same experience, so we can't rely on the same help that we had before, and it's just not working. And so what's so interesting to me is that there are so many innovative things that could be happening right now to help alleviate some of the stress points in order to retain the talent in the workforce. And you can't train thousands of nurses and thousands of doctors overnight, but we are looking at shortages that are going to require thousands of people to step in quickly. And if the bus or the plane is going and like we see it's about to crash, like we should do what we can to like stop, reevaluate, right, and see like, okay, this isn't working, like something needs to change. But what we've done is really doubled down on seeing how much you can squeeze out of the people who are already incredibly resilient people. We made it through 20-30 years of training, and we are altruistic, and that's why we went into wanting to heal people and take care of people. And so to see like it just doesn't seem to sit well with any of us, and we're being set up for, again, like what we're seeing in the news recently is really, really scary. Like, who wouldn't, without any reliable support or a team of people that knows you and knows how to take care of patients at their sickest and most vulnerable, if you don't have that team, none of us can be our best, right? And none of us can do our job without the team. Like, it's not a doctor and warm bodies, right? It's the trained doctor, the trained nurse, the trained respiratory tech, the trained, everybody in the room has a role. Like the OR is like, I always think of it like NASCAR. Like, you can't just throw a new body in there. And even, what's happening, I think, is in ambulatory medicine. I'm an endocrinologist, so I'm the opposite of, the OR. But we have fallen. I mean, I just took a new job. I don't have any staff, right? Like, so I don't have a nurse, I don't have an admin assistant, because we can't fill positions. So, it's all on me. Like, I'm making photocopies and like calling for records, and it's, like, that's going to be like, I can do it, but it's so demoralizing to know that like I'm not being used to like the best of my ability to like really help people, because there's nobody else around. And that, it's going to be, I'm hearing stories that are just, like this over and over, where people are just like, all right, I'm out. And it could be something small that's like the straw that breaks the camel's back, not to get back to Encanto, but it's always Encanto, right? Suba, go ahead.
Yeah, sure. I was debating for like an hour with my partner the other day about why it is that clinicians or physicians don't leave their current role. And I know we're saying a lot of people are, but a lot of people stay a lot longer than they want to. And there's this push and pull between, is it because people don't know that it can be different? And so we keep just accepting what is there because we've never experienced anything different? Is it because we don't have the power to make those choices, to demand anything different, or the group collective, the collective power? I can even maybe say the word union. Or is it because the system needs a change? And I'm sure it's some of all of it. But what you said, Eve, about just the altruistic part of what we do, I think really comes down to so much of it. Like, the last 2 years highlighted that when push comes to shove, at the end of the day, we are taking care of humans and we are here to help them. And so when everything was hitting the fan, every one of us and all of our colleagues stepped up and said, we'll do whatever needs to get done. As recently as 6 months ago, there were situations where we're still being asked to, staff new COVID units, new COVID teams. And there is still the struggle of, okay, well, are we going to pay people for the extra time that they're working and the added weeks that you're putting on people's schedules? And that in and of itself was still a tension. And we found out and this wasn't me or my institution, but this group found out that at the end of that call, they found out that the IT engineers that were being asked to work overtime during this time were getting paid more per hour than the physicians that were being not given a choice and essentially said you had to take extra time. And that felt to me like a straw that could break a camel's back. That like, you're asking me to come in, take extra risk, you know, all of the things that we all know are there. And then there are other people who literally can just sit at home and be on a computer and are being compensated and show more appreciation, it feels like, than what we're doing.
Yeah, it's a really uncomfortable feeling, no doubt. And I think we've all felt that exactly. Dr. Khan, I see, has joined the
Hi.
stage. How are you?
Hi,
Welcome.
hi, thank you for hosting this space. Just a different perspective. I'm a cardiologist and a cardiac electrophysiologist, and I've been in practice 21 years. So I think the experience of an office-based cardiologist or hospital or office-based specialty or hospital-based specialty might be different. Uh, if you are in cardiology, especially procedure-based cardiology, we generate a lot of money for the hospital. So, number one, we spend a lot of time in direct patient care. So, there's less EMR burden on us. So, even though I work full time, I'm given a lot of resources. So, we have scribes, we have PAs, we have nurse practitioners, 5 nurses. So, so some specialties are valued more because we generate more revenue, right? Um, Not because we're any more special than anybody else, okay? It's just that we're bringing in money. Number two is the more that you have direct patient care and uh, there's less paperwork and charting. The hospital provides so much resources for us. So only 40% of cardiologists and even fewer, only 36% of electrophysiologists report being burnt out because I guess we bring money in and we are given so much resources. So
I think you nailed it. Absolutely. That is a huge piece of it because you are allowed to be a doctor. I mean, I think there's a direct, indirect, relationship or inverse relationship between the amount of support that you have and the amount of the documentation burden that you're required to do, and whether or not you're burnt out or not. So, I'm the exact opposite as an endocrinologist, and I see others in here who are in cognitive specialties in the outpatient world that are, we're bang our heads against a wall doing prior authorizations, or our nurses are doing prior auths, so they can't answer the phones. And, I can't like get anybody to like hire, to like get a scribe or a virtual scribe. I'm like fighting to like get somebody to give me Dragon, so I can try and be more efficient on my own. And I think it is absolutely right. And I'm encouraged that you mentioned what you did, because what I think that means is like the system only works when each part of it is working. And so, to have the insight to say like, well, we're doing well because we have the support, like that's the way to say the support needs to be available to everybody. Because, even though endocrinologists don't do the procedures to generate the money, like you need us to control the glucoses so your patients have better outcomes. I mean, it's just indirect, right? So, if we all stood up for each other, I think it would be, and not just cardiology and endocrine, because obviously I actually think we work together very well. But like if the specialties with better support are less burnt out, we should use those as the standards, and we should all, we should make all the specialties like that so that we can keep the talent in the workforce. Because you can't do transplants without the cognitive specialties, right? You can't do orthopedic surgeries without the cognitive specialties, but the cognitive specialties are struggling, and so is primary care.
Yeah, I was just going
yeah,
to add that oh, sorry. I was just going to add that, yes, in terms of like the resources, I mean, it just really highlights that point that the more resources you have, you can unburden some of those tasks, which, are not, they don't bring you joy, right? Nobody has joy with like filling out um, paperwork and prior authorizations and things like that, right? I mean, and if you only had to do one a week, maybe things would be fine and it wouldn't be a burden. But when you have to do it over and over again, and you have to, if it takes an hour and you're doing, um, you're speaking to someone who is like doesn't understand the sort of the urgency of the situation, and you have to keep explaining, and you feel like you're banging your head against the wall. I think that's where you run into those issues. And so, sort of really highlighting the point that the more resources you have, it can really make or break sort of your day, right? So if you have a scribe and you're not having to chart at the end of the day, if you have someone who is really dedicated and able to have that the responsibility for taking care of those prior authorizations, or maybe taking care of some of the patient, phone calls that are easy to do, and it doesn't fall all on the physician, because those are all unbillable hours, right? So that's what it comes down to for us, right? Those are things that we have to do for patient care, but we can't really bill for them.
So until I had started listening to some of these chat rooms, I never actually realized that physicians do prior authorizations. There's not, I work for the Baylor healthcare system, and they're it's a multi-specialty, and we're 182 cardiologists and 15 electrophysiologists. I've never done a prior authorization in my life. I didn't realize that doctors are expected to do that.
Well, we're not supposed
This is
to.
terrible. I just want to give you an insight that it's incredible. I was shocked that not everybody has the resources that I'm sure maybe orthopedic surgery and cardiology and cardiac surgeons. So so many specialties like mine don't realize that physicians have to do prior authorizations, that physicians are directly calling patients back. So it's only through listening to this that we have an insight, because, we're all in our bubble.
And that is exactly why we bring these spaces together, because it's an idea generator. I want the space to be an idea generator. I want it to be a safe space for people to come listen and share. But I also would love people to be able to take what we're hearing and learning here and, go back to your own institutions and tell somebody a story that you learned here, because it's not that some doctors do this and some don't. It's that some doctors have to do this in order to get through their workday because there's nobody else to do it. And they, despite asking and begging and pleading, we're spending most of our day doing data entry and clerical tasks, and it's demoralizing. And the thing is, it's not hard, right? Like, I would be happier to be called in for an emergency, in the hospital for one of my patients, or to add on an extra patient to see. It's all of the other stuff. It's like the typing and the recapping, and the, patients are calling angrier because nobody's getting back to them fast enough. And they're getting all their results auto released, but we don't have any staff to help triage and explain. And so it's become like just a situation where I feel like we're all of the specialties without the support are sinking much faster. And so I would love to hear a story on our next spaces of how, this insight really like helped another specialty, or maybe we team up, maybe ortho and endocrine and, PM&R and cardiology, like they team up and, you have to make sure that everybody's okay. I don't know. That would be cool. Amanda, I want to give you a chance to speak as well, because I see you up here. Let me mute my microphone and welcome.
Thank you so much, Eve. And good, Natalia is back in. Okay, I think she got booted with connectivity. So I'll be concise. There are two issues that we're facing here, and I'll address exactly what you're talking about with the second one. But number one, we are looking at an estimated 23 million people in the United States alone living with long COVID. I can't do CNA work anymore. I can't do transcription, coding, billing anymore. I'm that resource. Name the specialty. I've been there 30 years. Some people are military brats. I'm a hospital brat. My dad's a hospital administrator. He broke a bottle over my head, and I woke up the next morning doing transcription at 15. But number two, all of that work, it's disappearing because I can't do that for $11 an hour. I will never get out of homelessness on $11 an hour in the state of Missouri, nor would I go back. I am so tired of getting sick all the time. I've been in bed most of the day with a heart rate all over the place. Maybe it'll be 40, maybe it'll be 140, but I can't go back to CNA work. I wish I could, but not for that pay and not right now.
Yeah, I think that's a really, really important point here, which is that so many people in the healthcare workforce are still feeling really unwell, are struggling with post-COVID sequelae, or have family members or caregiving responsibilities that have really changed. But agreed, I mean, especially we know the demographics of people who have left overlap pretty strongly with the demographics of people at higher risk for long COVID. I mean, I delayed the start of my first job because I couldn't think straight, and that was luckily a few months. But even now, I'm a little bit less, sharp. And I can imagine, I can imagine people who were just much worse off than me, and it would be impossible to have worked the first month that I had COVID. And we are seeing, we're learning. Luckily, we happen to have an expert in this room right now on long COVID, so I don't want to like pretend like I know what I'm talking about. But I will.
I'll help you with that.
So I will, but I think you're absolutely right that, on top of all of this, on top of the systemic strains and stresses to the system, on top of the, lack of resources and the high turnover and the chronic stress of having gone through what we've all gone through, we also have a workforce that is just not as well as we all were, when this all started. And, the failure to account for that, I think, is hurting the whole healthcare system as well.
Yeah, I mean, in terms of, we talked about lack of resources, right? I mean, even in our clinic, we're always sort of short on staff in terms of MAs and nurses and all of that. So that somebody has to take care of the work, somebody has to do it, and so that's where I think some of those issues come up. And there are a lot of, at least in our clinic that I can speak to, a lot of our older nurses decided they were going to quit during the COVID pandemic because they were being pulled in all these different directions because of things happening. Like all of a sudden now, instead of being in the clinic, they were being pulled to the units and floors and being asked to work there. And for a lot of people, it was just sort of, this isn't worth it. This is not what I signed up for. And so just in terms of, there's already these shortages, and then you have this amplification of those shortages through the pandemic. And again, same thing with burnout, right? And just sort of all these extra stresses. Burnout was an issue prior to the pandemic. It's just being highlighted and amplified now. So I think it is sort of a pivotal moment to sort of say, well, what are things that we can do, and sort of use this time to hopefully, make some changes for the better.
Yeah, and it would be really interesting to hear like what would be on, like what do people wish would would be, different in order to be less burnt out. Like I have my wish list, right? Like I want to not be tethered to a computer, and I want to be able to chart in real time and go home and not have thousands of messages. And I know that sounds like, to me there's like a fairy dream, but I would just be so much happier if I could do my job while doing my job, take care of people, and then be done when my day was done. And I know there are fixes that exist. There are solutions out there, a scribe, but why don't I have the autonomy to hire one? Or, a virtual assistant. But again, like I can't, it's like I don't have the autonomy to be able to get it because I'm a factory worker in some ways, and not me, but like all of us. And so how do we really kind of come up with like this organized list of things that like are going to be necessary in like more urgently in order to get all of us through this? Or because I know we all have one foot out the door, everyone has one foot out the door, some people have one foot and half of another, right? So I get calls every day from people telling me that they are about to leave, or they're going to leave, or they have a job offer. And I think that what I'm experiencing, what I'm hearing, is not being reflected in the acuity of the reaction from the business of healthcare.
Absolutely. And the key is, Dr. Bloomgarden, is that to know that for some people, all of those resources exist. So my scribe enters the data. He preps the chart in advance. My medical assistant enters the orders. My nurses answer the phone calls. My nurses and my PA and nurse practitioners do all the prior authorizations. So it's important to, and I'm an employed physician. So I'm just employed and I work in Dallas, not in a, not in an academic or university. So the important thing is to know that where there's a will, there's a way. There is a healthcare system that provides that for certain people. I need to now go and talk to the endocrinologists and the primary care people who work in my system. But what you're saying is possible, and there is money to do that. I don't know whether you're in practice or employed or academics, but it's horribly unfair. that that's happening to you, but those resources exist for other people, perhaps because I'm in Texas and it's fee-for-service medicine. I don't know. But everything you said is possible. And um,
Yeah, no, we know that makes it almost worse and sometimes to know it's out there and we still don't have it because we don't have enough autonomy or power to get it. But let's move over to Monica, Dr. Verduzco Gutierrez. How are you?
Hi, thanks. This is Monica Verduzco Gutierrez. I'm in San Antonio. I'm a PRNR physician and a chair of a department. So these things are always top of mind for me since I have faculty and I have staff and I have MAs, and those are people that I am in charge of. And then plus we have a hospital system that we work in and other clinics and services there. But yesterday, this is something that's been top of mind, and we're in a big part of my practice now is taking care of people with long COVID. And we have a multidisciplinary collaborative through our society. And we had a speaker yesterday talk about burnout that we had asked for someone because it's both, we're feeling it as physicians, but another term that I wasn't that familiar with that they brought up was compassion fatigue. And I think that's something that's different from burnout. And that's something that people can have both burnout, but also compassion fatigue, especially if we're now seeing, patients who are dealing with chronic issues, who we don't have answers for, who aren't getting better, or who are, getting really sick from a condition like so people with COVID, people with long COVID, people who just haven't had the usual care that they've had during a pandemic, and then put it on top of burnout. The other really interesting thing about, some studies, more recent studies, was who's impacted the most with burnout right now. And it's not just, yes, physicians, but actually more than physicians are residents, and then nurses, MAs, and then also in one of their studies in the outpatient setting was also women and persons of color. So if you think about people who have those intersectional identities, they're going to be affected more during this time as well. And things were changed. So, we're going to have a going away party for our nurse in our LVN and our clinics leaving, and I had another MA leave, and it's tough and it's hard. We take this very personally as physicians, but it definitely then adds more work to other people, changes our workflow to have someone else that's covering that doesn't know the work that I do. And even as a chair, I do prior authorizations, I do inbox messages, and but I even have to learn how to set boundaries as well. So if I at this level have to, I know that everyone else needs to. So I don't know, lots to say, lots of things that I learned, but my next study I think I want to do is on compassion fatigue, because I've done some studies on burnout, but want to look at that next.
Oh, I'm so grateful that you came up to share that with us. I think compassion fatigue is interesting. I feel like as an outpatient ambulatory endocrinologist, I'm like have endless compassion for the most part, but I have no tolerance for crap, right? And so like it's like stupid things like putting in the pharmacy for like the 11th time after like somebody didn't do it, like who was supposed to do it, like that drives me absolutely bonkers. But it's things like that that are like crushing me, like, you know what I mean? Like it's just a different set of stressors for every different specialty and every different office, but it comes down to like the same thing, which is, that we are just feeling overwhelmed, and we're feeling like our voices aren't being heard, and we really we want change that allows us to stay. Like, I think what we're saying here is we would all like to stay, or many of us would like to stay practicing medicine and healing and taking care of people and, doing what we're really good at. But the system is making it impossible to do our jobs. And when you sit within a system that's not working, and your ability to do your job well is really no longer an option, we then are in a position of, do we do our jobs less well, or do we leave? And I think especially with the news going on recently, and the questions about criminal charges and medical errors, and burnout worsens medical errors already, and then high turnover worsens, like, I mean, like, we're all a little bit scared. And I think a lot of this is probably going to push people to leave clinical medicine if things aren't really addressed quickly. And I think, things like, how about going to like documentation? Like, don't change documentation rules for us. Just go back to crisis standards until we get through this. Like, don't make me sit and chart for like, another 4 hours a night. Or, don't auto release messages or turn off the damn patient portals. Like there are things that are major, major pain points that with a flick of a button, we could say, you know what, this isn't working right now because we don't have the staff to address it. We're going to turn it off and we're going to do everything we can to retain our staff. And I'm not seeing any of that discussion outside of like spaces like this. So I just, wanted to, I know we have like 5 minutes left in the space, and I would love to not just continue hearing my own voice because my voice I talk to myself all the time. So whoever else has stuff to add, but I just, like, to me, what, I don't know what needs to happen next, but like I feel like we're all kind of screaming from the rooftops like, hello, does anybody see what's happening? And so now, now we need to pivot into like making demands for change that allow us to do what we're really good at.
I was just going to add, in terms of the bringing up the discussion about compassion fatigue, I think that's really important. And one thing I find is really important is also just to be able to talk about that, because sometimes when you have that, that lack of empathy and compassion, whether it's for yourself, for your colleagues, for staff, for your patients, it can feel really awful, and you might feel alone in that and sort of thinking like, oh my goodness, like what's wrong with me? There's something wrong with me. Why am I feeling this way? But being able to open the discussion up for it to sort of share that, you're not alone in this, and sort of ways to sort of help foster that compassion again can be really helpful as well. Otherwise, it can be really alienating. So I think that's a really important point that you brought up, Monica.
Amanda, I saw your hand up.
Oh, thank you. Another thing, I'm not sure that a lot of people also recognize how increasingly restrictive this is. I can't give or take a physician's order over the phone. I'm a CNA. You have to be at least an LPN in the state of Missouri. So and when we're talking about suing over medical, or if we're talking about criminalizing some of these medical errors, one thing that transcription did when that was still a thing before voice recognition took over, it was our job to make sure that we flagged any errors. And it always came back on us. It did not go back to the physician, but you basically are expected to know everything without the education. Did you mean 40 milligrams or micrograms? Or if you're talking fentanyl dosing in a NICU, you could kill someone. But we're so restricted with who can actually pass along these orders and who can do what kind of charting.
Yeah, that's a great point. The thing is, other businesses have figured this out and have figured out how to do things that are complicated. And yes, it probably takes funding, and there is funding in medicine. It's not going to the people practicing medicine, and so some of this may be advocacy for prior auth reform. Some of this is going to be reining in the insurance companies. Some of this is going to be, top down, disseminating the wealth so that there aren't specialties that go underwater and don't come back out. That's something that we talk about in endocrine is, are we going to exist in 10 years? Nobody's really sure. I think there are big things, but like my voice is not going to be that person who changes that. But the more that we have these smaller conversations, the more the conversations seem to, take on a life of their own, and they trickle up and they trickle over. And I think, it's an important first step to like voice, I think, what we're all kind of feeling, with the caveat that a lot has to happen that we may not have control over. And that's the other point of the space. And as we close in on our last few minutes, I think, there is a therapeutic benefit to having a peer space like this, even if we come out of this without any solutions, to be able to just discuss things that we're experiencing in the workplace and to hear others discuss them and validate our feelings and to provide validation for others' feelings is very, is really the essence of what it means, to be human, right? And we just like, I think these spaces are so lovely and so critical, and like everybody just kind of goes away with like a feeling of like, okay, that was cool to get together and just, share a moment in time, because, time is time. We don't have a lot of time, and we want to make sure we're making good use of it. And, I think it is, I'm glad that everyone is here tonight. I think what we want to do with this, with our Women in Medicine space, is to keep and hold a space for peer support, for idea sharing, for collaboration, for venting, and just, talking about bad days, but also, to to provide the community that, that we all really need right now. So I am going to stop being so cheesy, but I'm glad to see all of you here. If anyone has anything final to say, please do it, and then we will set up our next space and let you all know when it will be.
I do have something. I know you said some of the solutions cost money, but those solutions that cost money are probably less expensive than it takes to replace physicians who are leaving. And so I think at the system level, leaders and leadership and an administration needs to understand that. If we put a little bit of money into a scribe, that may be able to save the millions of dollars that we lose from losing physicians from burnout and having to pay expensive locums persons or recruiting new people. So it's worth the money.
It's so obvious and rational, and yet we can't seem to get it done. And so I think the question is, do we just need to make the business argument, write it all down, publish it, right? I mean, it's probably been done, but, just then amplify it, and just to keep on that, because I agree. It is so expensive what's happening now is going to be so costly, and is already so costly. That the solution, no matter how much upfront it will cost, is going to be a better financial choice, right? But it's an argument that is above my pay grade. That was supposed to be a pun, but I think you're right. I think you're totally right.
I think another thing that we're also, I used to see this all the time on the billing end. Say you send out a bill to the insurance company for $150 for a visit, maybe an EKG or something. They don't reimburse you $140, $150. They might give you $14. And I think that's where a lot of this has just gone off the rails. And we don't really know what goes on the insurance side. A lot of it is proprietary. And very few people are able to speak to that.
Yeah. Amen. So as we close this space on National Doctors Day, I am grateful that you were here. I appreciate everyone who came up to speak and everyone who listened. Thank you to Rocky for being my co-host tonight. And I think this was great. I think it's nice to have an intimate space, and I think I'll take away, good feelings from this, and we'll have the recording available, and, we're going to keep doing these. So if you have ideas in between, follow us, follow me, follow Rocky, follow Women in Medicine, which is, the umbrella organization. There's definitely a big gender piece to the burnout story, which we didn't even get into tonight, but we certainly can unpack another time. But, I'm grateful that you chose to spend some time with us tonight, and stay well and take care. And we will see you guys next time.
Yeah, thanks for being here tonight with us.